I'm Dr. Raj. I'm PGY3 internal medicine resident. So we'll be discussing diabetic emergencies, DKA and HHS. Okay. Everybody is listening?
Yeah, speak loud
Yes.
because the loud room is long.
Is everybody able to hear? Okay. Are you able to hear? Okay. So learning objectives for today is like how we have to know how we can differentiate diabetic ketoacidosis from HHS and other forms of ketoacidosis. Like we will learn what are the other types of ketoacidosis as well, and what is the pathophysiology, what drives the development of diabetic ketoacidosis, and how to interpret labs throughout the management of DKA during the initial diagnosis and during the resolution of DKA, as well as HHS. And we have to know how to manage both of these conditions. We have to identify how severe they are, where the patient should be admitted first from the emergency department. We have to know that. And if we really need escalation of care or not. And in the end, we have to prevent the complications. What are the common complications that are associated with both of these conditions? So we will start with the case. Can anyone read for me?
24-year-old woman with type 1 diabetes mellitus presents to the ED with following complaints from one day: abdominal pain, nausea, and vomiting.
Okay, so few questions, like what are the questions that you are going to ask?
She's compliant with your insulin regimen.
Okay,
Well,
that she's not compliant. Anything else?
Any fevers or like any infections?
Yeah, it's like I've been having nasal congestion, as well as I have the discharge coming from the back of the throat and some fevers. Yeah. Any other questions? No, not following. I have just nausea and vomiting, which has been ongoing.
Anyone else in the family with symptoms?
No one in the family has any symptoms. They are pretty fine.
Is the abdominal pain in a specific location?
Yeah, it's not in the specific, it's generalized, I would say.
Any recent surgeries?
No.
Did you miss the last dose of insulin?
Yes, I did because I was not feeling well. No, I don't have any type of urinary symptoms.
Is there any smell to your urine?
No, I didn't detect.
Any thirst, excessive thirst?
Yeah, I've been drinking a lot.
Frequency of body?
Yeah, I have been going to restroom like very often.
What does your vomit look like?
Yeah, it's like yellowish. I didn't notice anything else. It's just the food that I am eating and I'm just eating out. That's pretty much.
Has that ever happened?
Yes, it has happened with me in the past as well. Any other questions? No? Okay, so we will go ahead and so patient further states they have missed insulin from last 2 days due to cough, nasal congestion, generalized weakness, and low-grade fever. And they told us like temperature is 100.1 when they checked the temperature at home. And when we did the review of system, like from top to bottom, when we asked certain questions, they said like they have been peeing a lot and they have been drinking a lot from last few days as well. And when patient presented to emergency department, these were the vitals. So the patient was tachycardiac with heart rate of 132. Patient blood pressure was soft, 95/58. Patient was tachypneic, 28 was the respiratory rate, and the temperature was 37.8 degrees centigrade. On when we did the complete exam, and exam was remarkable for the dry mucous membrane, and the patient had diffuse mild abdominal tenderness. We didn't detect any specific area of tenderness. So these were the lab values that we saw in the emergency department. So patient was hyperglycemic with blood glucose of 650, was acidotic with bicarb of 7. Patient, they did venous blood pH, it was 7.08, and anion gap was 28. Potassium is 5.8, and sodium was 129, and serum osmolality was 300. Just want to know, like, do you guys know the normal value of anion gap? Like less than 12, like for most of the time is 3 to 12. Okay. And normal value of bicarb? Yes, good. And potassium?
3.5 to 5.5.
Okay. And serum osmolality? Okay, good. Yes. And so as you guys told me, anion gap should be like 3 to 12, and potassium should be less than 5.2, and 3.5 to 5.2, and sodium should be 135 to 145, and serum osmolality should be less than 280, like 260 to 280 is usually the number. So based on these values, based on the information that you have got so far, what do you think are the differential diagnosis? Okay. Diabetic ketoacidosis. What else? Good. Gastroenteritis. That's good one. No, it's not radiating to bake. What? Appendicitis? Yeah, you can keep it. Okay, can you be very specific? Like which type of intoxication? Okay. Intoxication. It was measured. It was measured, not calculated. Any other differentials that you guys think? Did anyone say? Okay. So these are the differentials when we see, like, these are the topmost differentials. Diabetic ketoacidosis, hyperosmolar hyperglycemic state, patient could be septic, maybe because of pneumonia or infection, gastroenteritis, and maybe starvation ketosis. So like now we need to know how we have to differentiate these conditions, because these are the conditions that can present like that, but with little bit of changes. So like diabetic ketoacidosis diagnostic criteria, that's the criteria that we are using from 2024 ADA. And they say patient blood glucose should be 200 milligram per deciliter or more, and patient should have history of diabetes, because it is not necessary that it should always be more than 200. It can be less in euglycemic DKA. We will discuss more about euglycemic DKA as well. Patients should have ketosis present. So either beta hydroxybutyrate should be more than 3 millimole per liter, or we did urinalysis, and that we checked on dipstick, it is 2 plus or more. So they usually check in the emergency department urinalysis, and then they find out like it is like 1 plus. So you cannot say like it's not DKA based on that. The reason is sometimes it takes time for beta hydroxybutyrate to convert into acetoacetate, and that's why it's not detected. So patient can have DKA, but it may not be detected. So the best measurement is to check beta hydroxybutyrate. Okay, and sometimes it takes time to check that. So for instant measures, we can do that urine analysis with dipstick. And acidosis. Acidosis with pH, and pH should be venous. We don't need to do ABGs in these types of patients until and unless there is any obvious reason, because these are very painful. And if there is no any hypoxia or like no any other respiratory condition that you think could be leading to anything, then there's no point to check. Patient are tachypneic, but they are not hypoxic, right? So the ABG and VBG, that's the only difference that they detect is ABG can tell you more about the hypoxia, like oxygen saturation, PaO2. Okay, so we are not doing that for this patient. pH, venous pH should be less than 7.3. Our bicarb should be less than 18, and the bicarb should be serum, not from the VBGs. This is very important because the bicarb that is checked from the VBGs, that is not accurate because it is checked from through the equation. It's not the exact bicarb. Okay, so these are the important things. So what are we gonna need? Like based on so that we can make the diagnosis of diabetic ketoacidosis. Which ones? BMP, good. Okay, for instant measures, maybe you not complete urine analysis, maybe just dipstick. BBG, good. Beta hydroxybutyrate levels. What else? NN gap is usually in the BMPs. Yeah, CBC sometimes we can do it, but it's not recommended all the time. Like if you see like there is no any severe infection or like there's like little suspicion for anything else going on, we can skip that. Like, but we usually do that. Like in ED, it's already done before you get these patients. Anything else? Yeah. So these are the labs that we need to do in these types of patients. CBC, CMP, VBG, and the electrolytes, magnesium and phosphorus, because CMP, potassium is included in CMP. Beta hydroxybutyrate levels, serum osmolarity, so that we can detect like what's going on because there are few changes in the management of HHS and diabetic ketoacidosis. So we need to know that on the initial labs, like when patient presented, how was their osmolality. And ECG. Sometimes these patients have significant electrolyte imbalances, and electrolyte shifts are like on and off, and there's not much going on. Sometimes we have to do it. Okay. And others are the like mainly the cause specific. Chest x-ray, if you feel like patient can have pneumonia, which might be precipitating diabetic ketoacidosis, then you can do that. Like just for upper respiratory symptoms, we don't need to do that, right? And blood cultures, if you feel like it's the sepsis that is driving diabetic ketoacidosis, and we need to know the organism, then definitely we can order blood culture. Or lipase, if you feel like patient has pancreatitis, or which can trigger DKA, by the way, but or like you are not sure what's going on, whether it's like just pancreatitis or DKA or both. Okay, so
Remember, guys, that DKA doesn't just happen, it happens for a reason. And we always treat the reason, whether it's an infection, whether they miss their insulin doses. So we treat the reason and we treat the DKA.
And even when it comes to the diagnosis, right? We just had a patient 2 days ago with a blood sugar of 600, and gap is 18, and bicarb is only 13 or 14. But the beta hydroxybutyric acid is only 0.8.
yeah,
In the urine, there's not much ketones too. Ketones are only 0, not even 1%. So that's why this definition, you don't always need to have a very strict definition. We have to treat that patient like a DKA because that patient had asthmatic symptoms, sugar 600. So these definitions are just there. Doesn't mean that you have to qualify all the three.
Mhm.
So at the end of the day, just a common sense. When the patient is severely hyperglycemic, dehydrated, with a severe anion gap acidosis, I would treat like a DKA. Even the beta hydroxybutyric acid is high, but not high enough to call the diagnosis.
Yeah.
Because anything above 0.3 is high, but here based on the definition, it should be 3.
Mhm.
But our patient is only 0.8. So we have to
Yeah.
treat like a DKA.
Yes.
So the definitions are there. You don't have to exactly follow those definitions.
And others are like common reasons like why ketoacidosis happen, and patient blood glucose may be less than 200 in these situations, and we have to differentiate this from diabetic ketoacidosis, and as well as from the euglycemic ketoacidosis, because euglycemic ketoacidosis also needs insulin, right? That's the management, and along with fluids, definitely fluids and whole like DKA protocol. For starvation ketoacidosis, usually the blood glucose can be low or can be normal. And for alcoholic, same, can be normal or low. For euglycemic, it's usually normal for most of the times. And for ketone levels, for euglycemic DKA, for most of the times, you will detect higher levels of ketones. And acidosis severity is more in euglycemic DKA. Insulin status for euglycemic DKA, they are like very much, like low insulin. And the common triggers, as the name suggests, for starvation is the fasting, malnutrition, for alcoholic binge, and for euglycemic DKA, sometimes early DKA can present as euglycemic DKA, or like if someone is taking SCLT2, that can trigger. And the key differentiator is technically the history and the physical exam and like what patient is telling you. That's pretty much for most of the times. So now we will go to the pathophysiology, what basically causes the diabetic ketoacidosis and HHS. Like we can see, like Dr. Ramsakal mentioned, diabetic ketoacidosis doesn't happen all of a sudden. There has to have like some kind of reason. Either it could be medication non-compliance, either it could be the infection, surgery, inflammation, which can lead to diabetic ketoacidosis. So all these conditions lead to the absolute like increase in the counter-regulatory hormones, which are mainly the growth hormones, epinephrine, cortisol, which promote a lot of gluconeogenesis and a lot of lipolysis. And there, at the same time, we have the insulin deficiency. So this promotes the formation of ketones because glucose is not going to the cells because of the insulin deficiency, right? So our brain can only use glucose for the energy, right? Or ketones for the energy. It cannot use anything else. So that's why our body has the mechanism to generate ketones, but it comes with some kind of side effects. So this is how it happens, like some kind of trigger that promotes the ketogenesis, lipolysis, and eventually like lot of ketones formation. And then these ketones are excreted, which creates a lot of osmotic diuresis, because glucose is going to attract water, and then this water is going to pee, and then eventually a lot of derangements of the electrolytes, osmotic shifts. That this is the main pathophysiology of diabetic ketoacidosis. So we have to start from the top, like what caused it, and we have to manage, and in the end. So these are the common precipitating factors. Medication non-compliance. So like in our patient didn't take it, probably, and the infections, and the most common infection that are like noted are the pneumonia, urinary tract infection, and surgery. As we know, surgery is a very high catabolic state because of the steroids and the epinephrines. For medications, including like steroids, antipsychotics, SCLT2, we already mentioned about the euglycemic DKA and myocardial infarction, which is again like bodies in the lot of stress, which can trigger diabetic ketoacidosis. So these are the precipitating factors. We have to identify these precipitating factors, and we have to make sure we are treating them simultaneously. Otherwise, you can manage DKA. Patient may be out of DKA, but after you discharge the patient, they are gonna come back. Or like patient might be here waiting for the discharge and their DKA is resolved, their DKA can come back while being in the hospital. So if we identify these factors, we can treat them safely and we can discharge them on the appropriate insulin regimen. So now, as we mentioned, what is the workup? And we have to classify the DKA based on the severity, which is the mild, which is moderate, and which is severe. We don't have to send DKA patients all the way to ICU right away because in our hospitals, we do manage these patients in PCU. Because the nurses are pretty much experienced, they know how to manage and they know how to run the glucometer, which is the software that we basically use all the time. So we need to know whether this patient will require aggressive monitoring and if you feel like this patient is gonna worsen and you feel like nurse is not gonna do because there is like so much already going on with the other patients, so then you can send sometimes the patient directly to ICU. But it is better to identify patients, which is mild, which is moderate, and which is severe. And severe patient, sometimes you will see like ED may not have called the ICU. And you would have to call the ICU just to make sure they know about this patient. Then they have in the mind like, yeah, we have to keep the bed available because if the DK is not improving, then patient may come here. Okay, so these are certain logistics when we are managing patients with diabetic ketoacidosis. So mild DKA, if you see like the blood glucose is usually greater than 200 and beta hydroxybutyrate is like 3 to 6 for most of the times. And you see pH is like 7.25 to 7.3 for most of the time and bicarb is 15 to 18. And the mental status is completely fine. They are at the baseline mental status. And for moderate DKA, blood glucose is more than 200, beta hydroxybutyrate is greater than 6 to 9, and pH is 7 to 7.25, and patients are like little bit drowsy. And for severe, pH is less than 7, and stupor, coma, like the mental status is completely deranged. So for the management of DKA, we need to know what is the basic management and what is the most important thing to do when we get the patients from the emergency department. And we have to see whether patient needs like is on appropriate fluids. That's always first thing that we have to see whether insulin drip has been started. And if it is not started, why it is not started? Was there any specific reason? And we have to see whether BMP is being monitored. If it is not being monitored, we have to check the orders. I will show you how to put the order and everything. So these are certain things. And we have to treat the precipitating factors. Okay. So for fluids, basically, as we discussed in the DKA, there is severe dehydration because of the osmotic diuresis and body is in the significant amount of water deficit. So we have to correct the water deficit first that is lost. So for that, isotonic fluids like balanced crystalloids are the preferred. And there are two balanced crystalloids, normal saline or ringer lactate. And usually they are started initially when patient presents to emergency department at the rate 1 liter per hour. Okay, and we have to replenish the volume loss at least 50% of the volume loss in 8 to 12 hours. We have to make sure, and for the volume deficit, it has to be managed with the isotonics fluids. Once we have like managed the volume deficit, just that happened because of the osmotic diuresis, then we have to start the patient on maintenance fluids. Maintenance fluids is not, we are not replenishing the volume deficit. Okay.
Quick question. How do you know if you're eubulimic and you've repleted the volume adequately? What do you check? What do you monitor? Exactly. So keep an eye on your urine input, make sure it's appropriate, right?
Mhm. Thank you. So twice of
Yes.
yeah.
Normal saline is slightly acidic, but it's still okay to give.
Yeah, so like if you can see, like you can monitor these patients based on bicarb as well. So it's not like that. But for normal saline, as you told, like it is acidic. That's the one thing. And the second thing is it has chloride, right? And the chloride, and if you are giving more chloride and there's bicarb deficit, so anion gap is going to be normal. So it's better to check bicarb in these types of patients. So this is how you can manage DKA in these patients, whether patient is getting better, is patient clinically getting better. So first thing is clinically. That's the first thing. Second thing is like you see like if the bicarb is really improving or not. And then you see the anion gap. So these are certain measures that you constantly monitor throughout. And we do labs all the time, like every 4 hours, BMP, magnesium, phosphorus, and for blood glucose, we do it like 2 hours. That's the like board recommended, but in our hospital, the nurses usually do every 1 hour because the software that we usually use is glucometer, and that by default it's 1 hour.
I think there's been studies that have done head-to-head trials on outcomes in DKA patients where they got normal saline, lactated ringers, it's been about the same.
It's same.
Yeah, so it doesn't really matter. Granted, we know that normal saline does have some acidosis
Yes.
with it, so, but that's what the trial showed. So So if they're volume depleted, typically normal saline is better to use up front, and then when they're like volume, then you can switch to LR. So, yeah.
I think these are expensive fillers. We try not to use, and there is no any specific benefit. So we try to use the fillers that are like cost effective, and already we know how we have to manage the patient and how we have to calculate certain things, bicarb and different things. So there are tools available. So we try to escape it. And twice of maintenance fillers. Then we see the sodium levels. What is the normal sodium level as we discussed? Yes, 135 to 145. If the sodium level is 135 to 145, which is basically the corrected sodium level, it's not the sodium that we are seeing on the initial labs. It's the corrected sodium based on the blood glucose because after 200, every 100 ml of every 100 milligram addition to blood glucose leads to decrease in the serum sodium by 1. So we have to first calculate the
I think
Huh?
1.6.
1.6. Okay.
For every 100 above 100.
Yes. Yes.
The sodium drops by 1.
Okay. 1.6. And we can use MedCalc. It can show you the corrected sodium level. If it is 135 to 145, then it's normal sodium level. When we have the normal sodium, we have to use the half normal saline, like 0.45 normal saline, right? And if it is low, like less than 135, then we have to use normal saline or like LR, like whatever. And if blood glucose is less than 250, then we have to use D5 or D10 with the rate 150 to 200. The reason we have to use D5, even though patient might be hyperglycemic or can turn into hyperglycemic, because as we already discussed, DKA is an insulin deficiency state, right? It's not just the hyperglycemia we are treating. We are treating ketoacidosis formation as well, right? So we have to like decrease the formation of DKA, right? So for the insulin, as we already discussed in the order set, we usually use, it's already mentioned, but for boards, we need to know how much insulin that we have to start the patient on right away when we see the patients with DKA. It's usually 0.1 units per kg per hour. That's the recommended, and we need to know that for the boards, it's the 0.1 unit per kg per hour. Because if we end up in the other hospitals where they don't have the resources, they don't have the software, we have to manage DKA by ourselves. Okay, so we need to know these numbers.
You guys give a bolus and an inch and initial bolus before you start the drip?
We usually don't give here, but like because we have the software, we just put the glucometer.
If there are logistic issues where you don't have a bed
Then
and there's this gap where they can't start the drip, sometimes in the ED, they'll give the bolus just to buy time.
yes, yeah. So same 0.1 unit per kg per hour. Like we have to multiply like 0.1 unit into whatever the patient is weighing. We just give it, and after 1 hour we start the patient on drip.
What does this mean?
Like we do it, you do it right away. We do it right away, like IM or IV.
Like a 70 kilogram man.
It's like
how would
7
you
units.
give Them 7 units initially.
Initially.
Then set up the drip.
When you say double dose six glucose does not drop from. What time duration is that?
Every we are checking blood glucose every 2 hours, so we have to see that, right? And but here we usually do like 1 hour. Just say like if in 1 hour we are seeing like blood glucose is not dropped with the rate that we want, and that's the recommended rate. Like we have to see it should be dropping by 50 to 70 milligram per deciliter.
And remember, you guys don't have to calculate that. The glucometer software automatically does it for us.
Right, but this
It's
is
for
what,
the boards.
But you have to.
if you don't
yeah.
have the glucometer,
Like if you end up in the hospital where there are like very limited resources, so we need to know that.
correct.
Okay.
Good.
And we have to half the dose. If you see the blood glucose drop is more than 90 to 120 milligram per deciliter per hour, like whatever the amount that we are checking, right? And why we don't need to drop so much of blood glucose right away? Because of the osmotic shifts. Because we don't drop the osmolarity to be dropping as soon as possible. Like we have to give some time. Because sudden osmotic shifts, like if we drop significant amount of osmolarity right away, it can lead to cerebral edema. And we have to hold the insulin drip if potassium is less than 3.5. Initially, it used to be 3.3 at some point, but now the new guidelines, ADA 2024, it is saying like 3.5 is the cutoff to hold the insulin drip. Because insulin drives the potassium into the cells, and then patient can have more and more hypokalemia, and then which can increase the risk of more and more arrhythmias and complications of hypokalemia. Every 4 hours.
It will be on the BMP. When you do the BMP 4 hours, you'll automatically see the potassium as well along with it.
Okay. So now electrolyte management. Like we have to hold the insulin drip if potassium is less than 3.5. And we have to replace the potassium with the rate 10 to 20 milliequivalent per hour if it is less than 3.5. And if it is in the range 3.5 to 5, then we have to replenish with every liter, we have to add 10 to 20 milliequivalents of potassium. It's per liter if we have the range 3.5 to 5. But if it is less than 3.5, it's per hour, because for most of the time it's running at 250 ml per hour. That's the fluid rate that we usually see all the time. So we are doing it like 4 times more of potassium if the potassium is less than 3.5. Okay. And we have to hold, we don't have to give potassium if it is greater than 5. Right? So anybody having questions regarding potassium?
Sahil, regarding the potassium in our order sets, I'm asking because I don't know. In our order sets, do we have a E5 half normal with like 20 of K?
Yeah.
They do.
So we
They
can
do.
just do that.
Yeah.
We do.
Yeah. Yeah, it has like all the orders. That
I mean, the Google Commander pretty much tells them
yes, it has everything.
everything's what to do.
It's just
The K2 and the fluids.
Yeah.
They'll tell them stop
it has
potassium.
everything. Everything means everything. They just put the labs, whatever, and it tells the nurse just you have to draw the labs right away.
And
So
if,
the nurse has to draw, and then she will put the values and then it will tell, okay, so now you can start the insulin drip. Now you have to hold the insulin drip. Now DKA is resolved. So it will tell the nurse, so we can now calculate the total requirement. So it's like, it does everything, but we have to know like how DKA is managed, how HHS is managed. Anybody having questions so far? So
Can you please repeat for every 100 above 100 minus 1.6 of potassium?
Sodium.
Sorry, sodium. Is it like actual or it's pseudo hyponatremia?
which the hyponatremia that happens usually and hyperglycemia, it's not the like true hyponatremia. Usually when we see the hyponatremia, we have to know whether it is hypertonic hyponatremia, whether it is euvolemic, like normal tonic, or like hypotonic. And hypotonic hyponatremia is the true hyponatremia that we really care about, because that's the disorder of the sodium derangement in the body. Rest other is either the lab error, because sometimes like increased lipid and protein levels can cause the lab error. That's the term that when we use like pseudo hyponatremia for that, like for that is one that is due to high blood glucose, or that we usually use hypertonic hyponatremia.
So we are not like you mentioned it's 132. We are not correcting that
No,
plus. We are
no.
lowering the plus.
No.
It's
No.
gonna go up.
Yes.
So okay.
Yes.
Yeah, I mean, you use the formula to calculate what the
To
actual
correct it.
sodium
Yes.
is,
Mhm.
knowing that you don't actually have to fix the low sodium.
Yes.
This is that real sodium level. It's just the lab is calculating it because the glucose levels are high. You have a hyperosmolar and hyponatremia.
Any other questions? Yeah.
Could you also go over the potassium again?
Yeah, sure.
Because it's like the total body is different from the cells, like the potassium inside the cells.
Uh-huh.
So I was just having trouble with like the insulin and when we stop and why.
Yeah. So we have to hold the insulin drip when potassium is less than 3.5. The reason is because insulin drives the potassium from extracellular to intracellular, right? So when like we are giving so much of insulin to decrease the ketone production in the body, so what happens, like the potassium gets low, right? Because there is more movement of potassium from the extracellular to the intracellular, right? So we have to hold the insulin drip because potassium is less than 3.5. Now it's going to be more low if you are continuing insulin drip. It will go down. And which can be life threatening. Like patient can have arrhythmia because of the hypokalemia, like prolonged QT, like bradycardia. That is something like we always see all the time.
And sometimes that can be the barrier for you to initiate the drip as well.
Yes.
And at times patient might go to ICU to get potassium replenished through the central line to start the insulin drip.
Yes.
Thank you.
Yeah. So we have to.
Can you repeat the question? Sorry.
Yeah. So you are saying, can I?
When we take out of the insulin,
Yes. Yes.
we have to about.
I got you. So if she's saying like if patient has hypokalemia and we held the insulin drip, right? And do we still have to manage patients with like rapid acting or any other form of insulin? The answer is no. We don't have to give any form of insulin. We have to completely stop. Like no any other forms of insulin. We have to be focused now just on the replacing electrolytes, right? That's the question that you asked?
Yeah, if we read the receipt hyperkalemia was topic.
Yeah.
You're saying
Stop every-
when you start the sub-Q insulin?
Sub-Q insulin.
No, you don't really see a lot of hyperkalemia from sub-Q insulin
No.
initiation. It's really with the drip. So once the drip is off, you have to stop that 3.5 number, that kind of,
Because
you don't see a lot of hypokalemia just from sub-Q insulin.
Because with the IV, everything is going directly to the serum, and that is going to the transcellular shifts. But with the sub-Q, it has a very slow absorption rate, so it doesn't cause the risk of hypokalemia through the subcutaneous when we shift. We haven't seen any patient having hypokalemia on floors with sub-Q transition.
Yeah, it's not,
Yeah.
it's not.
Also, the
That's-
ketoacidosis is resolved, but if
Yeah.
you're switching,
That
is that what you're gonna say?
Yeah, I was gonna say,
Yeah,
yeah.
so you're worried about it. You're not as worried about it going low again. Ketoacidosis that was present in the first place is now resolved by the time you
Good.
transition to sub-Q. So you're putting them, it's not like you're stopping their insulin forever completely. You
So-
transition them to insulin in a
So-
different form.
So, good, thank you.
You're saying, yeah.
So, I'm sorry, guys, this is the cell, right? This is the cell, okay? Remember, when you have DKA, what do you have outside the cell? It's acidotic, you have a lot of protons. How does the body compensate for the protons outside? They shift the protons inside the cell, but you can't just shift a cation inside the cell, you have to balance it. Otherwise, it'll be like, positive charge or negative charge. You have to balance it by taking the potassium out, and that's why they get hyperkalemic. But when in acidosis, right, the potassium is high in acidosis, and alkalosis, the potassium is low, right, in metabolic alkalosis. When you, as Dr. Chris was saying, when the acidosis resolves with DKA, the body no longer has to do this. So you have less of an incidence of becoming hypokalemic. It resolves. You understand? And insulin and potassium ride the same pump, right? When you give insulin, potassium rides with it. Okay, so if the acidosis corrects, this is why you don't get the risk of hypokalemia.
Okay. Any other questions? Yeah,
Do we start in DKA management with just like a peripheral line access? Do we need, so if we have like a 2 peripheral line is enough and then we escalate access? if
Yeah.
Needed? Or
Yeah.
any like?
we can start.
What-
Yes, we can start the management. Like two peripheral lines are more than enough.
Sorry, you said here we do insulin drip in the floor or PCU?
Yes,
That's what PCU.
yes. Usually in our hospital, it's usually the 4 south where we do. And for sometimes, like if we have like cardiovascular patient, they usually do in 4 northeast as well. These are the 2 PCU floors where we can do insulin drip. Otherwise, sometimes you will see there will be situations when like you will have to transfer the patient because of the no bed availability in both floors, like where we can do insulin drip. I had one patient, we could have managed that patient on floors as well because there was no any bed available in PCU. Then one of the bed was available, then we had to transfer that patient at least for a few hours so that if the bed is available, then we can transfer the patient.
Transfer to ICU.
Yes. So this is very common scenario that you will encounter. If you feel like there are no beds available in PCU, if nurse is saying, don't manage these patients in med surg units, never ever. And you will have to call ICU sometimes and you tell them scenario. Sometimes nurse may not call for you. Okay.
I think this is like the most relevant slide for boards because they will literally ask you, they'll give you a slam dunk DKA and ask you what to do first. And the choices will be replace potassium, start the insulin drip, give them phos, some random thing. So you gotta know that 3.5. So memorize that when you leave here, before you leave here. If the potassium is less than 3.5, replace it for the insulin drip.
Okay. So for bicarb, now the question should be if patient has acidosis, then why are we not giving bicarb and insulin DKA? So basically, bicarb changes the acid base shifts in the body, and it's not recommended. And there are multiple trials where it hasn't shown any type of benefit. Right? So we only need bicarb for the very, very severe DKA when pH is less than 7. That's the only reason when we need bicarb. First, it used to be like 6.9, but now they've changed to 7. Okay.
Is it always if less than 7 or if it's persistent so initial treatment? We will give a comment.
So if it is less than 7, then you can initiate. Yeah. So we cannot wait for like 4 hours of BMP because these are the patients. If you expect like if patient's pH is 6.9, probably they are not gonna be within themselves. Like they are gonna be very, very stupor, like maybe severely altered. And this is gonna worsen if we are not initiating right away. If they need it, then we have to start it. Yes. Okay. So for phosphorus, we are commonly seeing like in that insulin, like the insulin drives the potassium from the extracellular to the intracellular. Same happens with the phosphorus. Insulin also drives the phosphorus from the extracellular to intracellular. You will like commonly encounter phosphorus levels very low in these types of patients. Now the question is whether we have to be that aggressive with the phosphorus replacement. The answer is no. They are saying like there is no any benefit if we have to we have to replace phosphorus if it is less than 1, or there are significant muscle weakness or respiratory compromise. If the levels are like low, and if you see these patients with these symptoms, then definitely you have to give that. But if a patient is like walkie-talkie, like completely fine, we don't have to do that. Okay. So for now, like how often we have to monitor blood glucose? That was the question asked. For boards, we have to monitor blood glucose every 2 hours. But usually, like here in our hospitals, they monitor every hour. And for lab monitoring, we will have to monitor BMP, electrolytes, and venous pH. But we don't need to monitor venous pH. If we can see patient is getting better, and if you are seeing like bicarb is increasing, then we don't need to monitor pH. We can relate the information like with the clinical picture and with the laboratory findings then. So BMP, MEG, FAS, and these are the major labs that we have to order. We have to see whether nurse is doing or not. We have to make sure they are done at the appropriate timing. We are not skipping these labs. So when we say DKA is resolved, anyone? Okay. What others? Yeah, bicarb is increased. Okay. They are not going to be undetectable. Even if you check, you can make sure like they can be low, but they are not going to be undetected, because sometimes what happens like even if they are like they can be high because it takes time for the keto acid excretion and then in the urine. So venous pH is greater than 7.3 and bicarb is greater than 18. Like this is one, and the plasma ketones less than 0.6, and patient is clinically doing fine. When they presented, they had abdominal pain, nausea, vomiting, significant weakness, severely dehydrated. And if you do exam, patient is doing fine. They are not complaining to you anything. And then you see the like these labs, then you have the idea like, okay, now DKA is resolved. Okay. And now you saw like DKA is resolved. What should be the next step? Because that patient was on insulin drip, right? What we need to do now? Transition. Good. So how do we do transition? Does anybody know? Yeah. Okay.
12 hours.
Okay. Yes. Yes. So basically, we are calculating the total insulin requirement, because that's the regimen that we are going to start the patient in the hospital, right? She's saying like if patient was on insulin trip for 6 hours, like they were on 7 units per hour. Like we are gonna do like 7 into 24. That's the requirement of the insulin that patient needs in 24 hours, right? So you will have to change that amount of insulin into like long acting and the short acting, right? That's the initial recommended regimen. And which are the long acting insulin? Okay. Yeah, glargine, Lantus. And what are the short acting? Lespro and Espart. Good. So once we calculated the total insulin requirement, then we have to divide into 50-50, like 50% of the long acting and 50% of the short acting. Okay.
And the 50% of the short acting, you
Should be
divide it by 3 to decide how much, like if, like example,
yeah.
like if they're using 60 units of the insulin on the glucomannan in 24 hours, you're gonna give them 30 of the basal long acting, and the other 30 units, you're gonna divide that by 3 to give 10 of preprandial with 3
Breakfast, lunch, da-da.
Okay. So now transition. Once DKA is resolved and patient can eat and drink, make sure patient is eating and drinking, because then the value is going to be changed. Patient may become super hyperglycemic all of a sudden, right? Patient is eating and drinking means their clinical status is better. And you see on the laboratory wise patient DKA is resolved, then you will have to transition IV insulin to subcutaneous insulin, right? And subcutaneous, first thing is total daily requirement of the insulin, right? And usually what we have to do, like we have to ask from the nurse, then they can see in the software how much glucomender is telling them, because rate is not going to be same. Sometimes it's going to be 7 units per hour. Sometimes it's going to be 4 units per hour, right? So it's going to be tough when we have to calculate the total daily requirement of the insulin, right? So we have to ask from the nurse how much it is showing in the glucomender, how much insulin was used in 24 hours. If it is used in 24 hours, if it is not, then they can calculate the total daily requirement. Okay.
You can give it a good guess by saying 2/3, 1/2, but.
Yes. So better to check it for the nurse, how much software is showing to them. Okay. Then divide the total regimen in half long acting and half preprandial. And then the half preprandial should be divided in 3: breakfast, lunch, and dinner. Okay. And one thing that you guys have to make sure all the time is you are transitioning insulin from the IV to subcutaneous 2 hours before stopping the drip. You are not stopping the drip right away and then start the patient on subcutaneous. The reason is because when you start the patient on long-acting insulin, particularly, this is how we have to do. We have to give long-acting insulin and we have to give the Lispro if patient is eating at the same time, right? So long-acting insulin takes time, at least 2 hours to be in our system, right? It's not going to be released right away. Okay, so then patient can turn into super hyperglycemic. So we have to transition. Once we know DKA is resolved and patient can eat and drink, we have to calculate total daily requirement. And once we knew the dose, then we have to give 50% of the long acting. And if patient is eating at the same time, we have to give them Lispro, and then we have to start them on the regular dosing. Okay. Did you guys understand? Because this is going to be the most important thing, right? Anybody having questions? No? Okay. So that's pretty much about diabetic ketoacidosis. Anyone having questions?
Just had a quick supplement.
Yeah.
You had a good question about the hyponatremia. You understand why the hyponatremia is a pseudo hyponatremia, right? It's not real, right? Because you have all this glucose in the extracellular. Look at my drawing there. You have all this glucose in the extracellular space. What's that going to do? It's going to pull water by osmosis from the intracellular to the extracellular space. And when it pulls water to the extracellular space, the glucose is going, the sodium is going to drop because it's diluted, right? So it's a pseudo hyponatremia.
But they are not at risk of seizures, like even drops like pretty long.
No,
not-
that's why you correct
not a
it
true-
for
it's
the
not a-
glucose to get that's why you correct the sodium for the glucose to get the real sodium level.
Yeah, so it's just possible to have an actual hyponatremia on top of the pseudo hyponatremia. So you need to correct it to see what number they're actually at.
Yeah,
Is it a real hyponatremia or not?
and treat the corrected value.
Yeah, so correct the value is what the.
Dana. You have to stop it. Okay,
Screws through.
that's fine. Then,
Jaldi, jaldi kar.
okay, so we have to stop then.
Right, so there's another topic number 2 is the HHS, correct? But that is important too, but it will take at least 15 to 20 minutes to do that, and I don't want to shovel that down your throat right now.
Yeah.
So we are stopping it and you will do the HSS at the next available.
Yeah, like we can do like 15 minutes presentation.
At
Exactly
some
right.
other.
Right.
Yeah, that's fine.
Because we have patients in the clinic scheduled at 1:30 and you all have to discharge patients and then end. Yeah?
The order sets.
Yeah, I can show them the order set.
So just real quick, show the order set so you know what they're.
So that's the order set. So this is the order that we have to put: glucomender, DKA, and HHS. Like if you type in the orders, glucomender, there are two types of glucomender protocol. One is just for hyperglycemia that we don't use for most of the times. If patient blood glucose is not dropping, even if we are giving the best regimen, so then we do just for the hyperglycemia. That's another one. One is for the DKA and HHS because it has the proper amount of fluids that patients need, right? And because you have to monitor electrolytes all the time, right? Because this is going to be a very big emergency as compared to just having hyperglycemia without having DKA or HHS. Okay, so you have to make sure you are putting the correct order, which says DKA and HHS. Okay, and then you will have to just put the order, then nurses can see. Okay, and if you see the orders like general diet, if you feel like there is no any right or wrong, for most of the times we don't, we can start the patient on insulin, patient on diet. The reason is like, there's no point like patient should be NPO. There's every guideline is saying like patient can eat or drink, but most of the time when patient have already nausea, they are not gonna eat. So you have to make sure, right? So we are not worsening more nausea, right? So that's the general fluids. For fluids, if you can see, it's done by itself. Like you have to just, it will be clicked. Okay. So you see like step 1, LR with the insulin infusion, and then LR. Then they are writing if it is blood glucose less than 250, they are putting the patient on D5 as we discussed. And insulin drip, like in our hospital, it's not like 0.1 for most of the times. Like it's the nurse driven protocol, and whatever the glucomender is saying, this is how they usually put. So,
She has a
and
question.
yes.
She has a question.
Yeah.
I haven't been on the inpatient side yet. Do we have like that glucose tab where it's like the charts and?
Yes.
Yes, we do.
Yeah. We have the glucose tab, exactly the glucose. All you have to do when you open the Epic right away, and when you open the patient, so you have to just type the search bar and you write glucose where they can show you. And where it will be like what was the blood glucose and how much insulin has been given. Usually we don't use for the amount of insulin that has been used in DK or HHS because sometimes they may not write it, or sometimes the rates are changing very frequently and it's tough to calculate, right?
That's why you said talk to the nurse.
Yeah. For others, like for those patients who are on the floors with the subcutaneous insulin regimen, that's the best step to see. Okay, a good question. So that's the order. And now once DKA is resolved, now the order is like transition glucomender. The order says like transition IV to physician directed subcutaneous insulin management. Just all you have to put this glucomender transition IV. Then it will show you. same. It will be, and then you have to select the diet because patient must be eating, right? And this is how you have to select basal and preparendial, 50% and 50%. Then you divide the preparendial into 3 doses. Okay. And take home points like crystalloids are the best management. Always consult the diabetic educator because most of the times like patient don't know how to manage diabetes or how much insulin they have to use, how to use the subcutaneous insulin and everything, and always try to simplify the regimen at discharge because this is the important thing. Whatever patient takes, because sometimes you will see patients have insurance issues, then you have to convert long acting and short acting into NPH, which is the intermediate form of insulin that is very cheaper, widely available. So as usual, best treatment is the one that patient takes. Okay. Any questions you can ask? Otherwise, we are done.